All right, well, good morning, everybody. Thank you for joining us this morning, and thank you to everybody online and the sponsors of our grand rounds. It's really a pleasure for us this morning to have our friend and colleague, Dr. Peter Noseworthy, join us. He is the professor of cardiac electrophysiology with the Division of Heart Rhythm Services at Mayo Clinic in Rochester. He's the medical director of business development. He's done a lot of work with the Kern research group in Mayo and has really developed unique expertise in AI ECG, clinical trials, pragmatic trials, and as you know, I know for many here in the audience, that's something of great interest. This issue of pragmatic trials and AI ECG. So I think we're really here for a treat to learn from him about the application of artificial intelligence to the ECG and the emerging opportunities with this. So Peter, really thank you for joining us.
Great. Well, thank you very much. Can you hear me okay? Probably, right? Good. So Peter Noseworthy, as you heard. I'm a cardiac electrophysiologist. And I think what I can do is tell you the story of how we're developing AI models at Mayo Clinic using our retrospective data, how we've tested those prospectively in clinical trials, and I think most importantly, how we're deploying them at the point of care, and I think changing the way that we use ECG. Am I okay? Okay, yeah. So I didn't set out to do this kind of work. I'm not an engineer. I used to do big data analytics, health outcomes. I did a little bit of work in complex genetics during my training. But I sort of found myself in the right place at the right time. And there's a lot of cardiologists at Mayo Clinic who are starting to develop this kind of work. So I'm presenting, but there are at least a dozen cardiologists, data scientists, AI engineers at Mayo who have contributed to this work. About 6 or 7 years ago, our chair asked me to run the ECG lab, which I thought was sort of a boring administrative post. We all have to take on these sorts of roles. But what he made me recognize was that because we have this very large ECG data set archived over decades, all the way back to 1990, with 12 million high-quality ECGs, well archived, all linked to our medical record, it was exactly what we needed to start to develop AI models and try to deploy them at the point of care. So at around that time, we started hiring AI engineers, embedding them in our practice, and it became like a test case or a sandbox for innovation around how to apply AI to medicine. And I think it's been very successful. So I will, a lot of the work was sort of funded through various grants and things. We have protected a lot of the IP, so we've got a bunch of patents and disclosures. And some of the work, that IP has been licensed to a sort of a daughter company that we created called Anumana. They hold all of that IP, and they're helping us with sort of figure out how to get it into the hands of consumers and patients around the world. The regulatory process is very expensive. We couldn't do that on a research budget. So if you think about ECG, it's like the one part of cardiology that has changed almost not at all for like 100 years. And I think we're just at an inflection point where it's really starting to change. So on the day that I took over the ECG lab, I had my ECG done because I wanted to see what it was like to be a patient coming through the lab, have an ECG. So this was my ECG, normal sinus rhythm, normal ECG. Great. But it's not all that informative. And if you think about this, this is a physiologic inscription of my heart activity. There's probably a lot more information in those squiggly lines than just normal, abnormal. So this is how it would have been read 6 years ago at Mayo. And this is how we would read it now. So this is like my epic chart, sort of scrubbed of anything too embarrassing. But if you go to the cardiology tab, there's this button here called AI ECG dashboard. And when you click on that, it runs all the models that we have on all of your ECGs. So I've only had one ECG, so it's not all that interesting. But if I had 30 ECGs, you'd see all kinds of trends in these models. And what you see is that the models are really amazing in the kinds of things that they can tell us. So it estimates my age at 37. I was 39 on the day that I had that ECG done. The probability that I was male, 98%. So everybody in this room, or most of us, read ECGs all the time. Can you tell somebody's age, or male or female? Probably not. But I think that's, and we don't need an ECG to tell us if we're male or female or how old we are. But it's proof that there's a lot of information in even just a simple tracing like an ECG that's sort of hidden in plain sight. Much more interesting things are, what's my ejection fraction? We obviously don't use an ECG for ejection fraction, but if it can be a surrogate, there are all kinds of times when we can't get an echocardiogram, and if we can get some information from an ECG, that would be valuable. And then what's the likelihood that I have undetected atrial fibrillation, even though I'm in normal sinus rhythm today? Or what's the probability that I have hypertrophic cardiomyopathy, aortic stenosis, amyloidosis? And now we have, like, I'm not exaggerating when I say dozens of these models that are in development. And once they're published and we think we have demonstrated that they perform well in diverse populations and things, then we start to deploy them on this dashboard. So I was lucky. My ECG didn't show anything too worrisome. But here's another relatively young person who felt like he was healthy, but his sister had died unexpectedly. And his ECG, like mine, was read as normal sinus rhythm, normal ECG, but our AI model said it looked like low ejection fraction. And indeed, when he got an echocardiogram, his EF was 18%. And probably what had happened is his sister and he share a genetic cardiomyopathic process. So he went on to get this diagnosis and other family members. But the question is, like, what if his sister had come in for an orthopedic surgery or something and got an ECG? Could we have picked up this before she had a sudden death? And those are the kinds of things we're interested in testing prospectively. So I'll start at the beginning. When we first thought about how we would develop and deploy AI, we thought we would try to do what humans can already do, essentially read an ECG. What's the rate, rhythm? What are the abnormalities? Is there left atrial enlargement, that kind of thing? And we can do that. Our thinking was, we have a very centralized process for ECG interpretation at Mayo. We just have an ECG lab where they're all read centrally. So we read around 400,000 ECGs with a team of about 10 or 12 cardiologists and about 130 technologists who do the initial ECGs, and you've seen the workflow. But so we thought we could, maybe if we could streamline that work, we could get better quality, more consistency. Maybe we could read for other hospitals as a sort of a service, and we could scale from 400,000 a year to 4 million a year. That was our original goal. It's actually pretty tough to do. But what's much more interesting are these other things that I've already shown you. The fact that we can use AI to see beyond what a human can see. And in that case, what we're doing is we're bringing new value to an old test. So, it's not just what's the rhythm and what are the abnormalities, is there an MI, but it becomes much more richly informative. And you take a test that costs us pennies to perform, essentially, and use it to innovate. So comprehensive ECG interpretation, this was our first attempt, and it was a hard process. So we use what's called a convolutional neural network, which is a lot like the technology that's used for image interpretation. It essentially breaks down this tracing into convolutions, which are like little features. But they're not features that we're used to seeing, like QRS duration, QT interval, these sort of discrete measurable things. It's sort of, what's the angulation of this part of the T wave? And we would essentially train these binary classifiers for any code that you could put on an ECG in the Muse system. And for each individual code, it worked really well, but it would spit out like a laundry list of things. And it wasn't all that helpful because it didn't read like a human ECG. So then we learned how to train the models to learn the associations between codes. And then before ChatGPT and transformers were big, we did deploy a transformer to take that and then create a sentence that read like a cardiologist would read the ECG. And that allowed us to do like a Turing test, if you will. Essentially, give a report and say, does this look like a human report or an AI-generated report? And we compared the Marquette read, which is that analog, what gets spit out at the top of the ECG automatically, our AI read, and then the ECG read, which was a combination of our techs and our cardiologists overreading it. And it did pretty well, but unless it's 99.999% accurate, it's not going to replace the workflow that we have. So this beats the current computer program, but what we realized is we're going to have to do a lot more work to fully automate ECG interpretation. So everybody can take a deep breath. We're not, your jobs are secure. But it's really, the cool stuff is really seeing beyond and doing the things that we wouldn't otherwise be able to do. So I'll show you 3 examples. I've already kind of alluded to them, but the first was low ejection fraction. And what we did was we took our ECG database and we paired it to our echo database. And we used the same technology, a convolutional neural network, to train a model to say, is the EF low? We had to take a binary cut point. Is it low or is it not low? And we used 35% as that. And we measure the performance of any diagnostic test, any binary classification problem as the area under the receiver operator curve. So if the area under the curve is 0.5, then it's just a coin flip. It's just a guess. And if it's 1, it's a perfect test. It's perfectly sensitive and perfectly specific. But the tests that we use all the time in clinic, like a stress test, maybe has an AUC of around 0.7, maybe 0.8, mammogram around 0.7, the Chad's VASC score about 0.68. But these are things that we use all the time. And we're getting AUCs for this model of 0.93. So really a pretty good test. Now, it's not diagnostic, of course. And for low probability diagnoses, there can be problems of low true positive rate or positive predictive value. But it performs well enough that we do have some confidence that it's going to be useful. And then we go on to validate it in other populations. The other thing that we did is we made these models available to everybody at Mayo. You probably used to use these models a lot, but basically by putting it into the electronic health record and making it widely available, it made like a cottage industry for testing these kinds of models. So a group of emergency department physicians in Florida said, well, could we use the initial ECG when somebody comes to the emergency department as a determinant of whether they're short of breath because of heart failure or asthma, COPD, pneumonia, COVID, pulmonary embolism. Just say, because everybody gets an ECG when they walk in short of breath. And it performed pretty well, almost 0.9, and actually better than a BNP. And of course, a BNP, you've got to draw blood, and then you've got to wait for it to result. Whereas the ECG can be done in triage and alert the cardiology team or whoever it might be that there's a heart failure patient in the emergency department. One of my colleagues in the CCU looked at it amongst CCU patients who were really sick, universally sick. And in that population, it was diagnostically valuable, but also prognostically important. So interesting in that way. Mayo's criticized because our population is not terribly diverse. It's an upper Midwestern population that we're kind of familiar with. We obviously have Florida and Arizona as well, but we always want to make sure that these models are not perpetuating some sort of diagnostic bias that we might have in the way we practice medicine. Because if we start relying on these models and there's some sort of disparity or blind spot that's baked into the data, then all we do is perpetuate that in perpetuity by making these models. So we always have to check and make sure that they're performing consistently across various populations and subgroups. At least for the low ejection fraction model, the AUCs are almost identical to a couple decimal points. So at least for this model, it seemed like it was pretty robust to variations in the ECG. After we had developed this model, we had an AUC of 0.93. We thought, well, that's a pretty good test, but what if we just add a couple more variables to it? If we add age and sex, could we get essentially a perfect test? I had done a lot of work in risk modeling and these sort of big data analytics, and generally you build these models, and the more you dump into the model, you usually get a little bit of incremental benefit. So we did that. We added age and sex to the model because it's on the ECG, and it didn't improve the model performance at all, like not at all. It made absolutely no difference. And that was a head scratcher for me and for the clinicians who were involved in this work. But the data scientists said, no, all that means is that the model already knows everything it needs to know about age and sex as it pertains to the ECG and this outcome simply by looking at the ECG. So that was the first hint that age and sex are probably encoded in the ECG, essentially. So when we look at our AUC for sex, it's almost perfect. It almost always gets it right. So much so that in our dashboard now, if it gets the sex wrong, it tells us that there's something very unusual about that ECG. So sometimes it just means the leads are in the wrong place. Or maybe they have complex congenital heart disease and the model has just never seen an ECG that looks quite like that. So what we do is, this is like our internal control. And if it fails on sex, then we kind of gray it out in the rest of on the dashboard and say, there's something unusual about that ECG, discount it a little bit or put it in some context. And then we have a pretty good performance in terms of age. Now, if it was absolutely perfect, as in the ECG age and the chronologic age were identical, then there wouldn't be any new information gained from that. But there's a good correlation here, but there's still some variation. So it raises the possibility that we're actually measuring something a little different than chronological age. Maybe we're measuring physiologic age, or maybe this variable, like, is this patient less healthy than this patient? Or what about this 90-year-old who looks 10 years younger? Could we use this as a risk stratifier for perioperative risk or for mortality? And we've looked at our TAVR populations, and our anesthesia teams are interested in using this as a risk marker. A lot of work to be done on this, and as sort of a different group, but I think it's very interesting. Can we use the ECG as sort of a marker of physiologic age? This is just a sort of a fun case, but this patient was a little bit older than his chronological age and appeared to be aging, and then seemingly overnight he got about 20 years younger. Do you want to take a guess as to what happened? I always like to hear what people say. Tell a lot about the audience by what they think is going to, well, people often say, well, he went on a diet, a bariatric surgery, whatever. He actually had a heart transplant. So, really kind of cool. Now, in retrospect, it's a new heart. It's going to be a new ECG. It's going to be a new model output. But we were sort of digging through and figuring out where this model failed. And when the first example you look at is actually a heart transplant, it was sort of like, wow, it's valuable on a population level, but actually on an individual level, it's telling us something kind of cool. So we were putting a lot of effort into developing these retrospective models, and Nature Medicine issued sort of a call to say, we've seen a lot of these retrospective models look really promising, but once they're deployed in the wild, they don't work, and we don't want any more of those papers. So go and do a prospective trial and show us that this actually has an impact on clinical practice. And we were already in the process of doing that. So the first study we were doing, we called EAGLE, which is ECG AI-guided low ejection fraction testing, or something like that. A little awkward, but EAGLE, like the eagle eye. So what we did is we used our health system. We have a Midwest health system, about 30 clinics across the upper Midwest. In general, primary care is delivered in these care teams. So you have clusters of doctors and providers working together. And we could randomize whole groups of providers. So it's called a cluster randomization. And all we had to do was go into the electronic health record and turn the model on for half of the group and then off for the other half. And just asking a very simple question: if primary care doctors and nurse practitioners and providers of all sorts have access to these models, are they more likely to diagnose previously unrecognized low ejection fraction? So, and we could do this very quickly at very low cost because it's just flipping a switch electronically. And we didn't consent the patients, we consented the providers to say, do you want to be a part of a trial where you're either going to get AI access or not? And then do with it as you will, or as you wish. So we were able to enroll like over 30,000 patients in a very short period of time. What we did is we created a report that went into Epic. So if they were clicking in the document viewer looking at an ECG, it was like addended with PDF. So before they saw the ECG, they saw this report. And it would say screening is negative or positive. And then we have something that's kind of like up to date, but it's our own version of up to date called Ask Mayo Expert. And they could click there and it would tell the clinician what to do with asymptomatic LV dysfunction, because these are primary care doctors. They may not sort of know what to do with that. And then if they wanted to read about it, they could link to the paper and a little bit of detail like that. So just essentially just giving them the information they need to use the AI. And the primary finding was that about 1 in 50 patients walking through a primary care clinic who were not previously known to have low ejection fraction were detected to have low ejection fraction during the trial. And because we took a very pragmatic approach, we didn't say they needed to get an echocardiogram, we just gave them the results. Then we only bumped up echo utilization a little bit, and only in the population that had the positive alert. So we ended up alerting in about 6% of the population. In those patients, about 38% were getting an echo anyway because they were coming in with some cardiac complaint that prompted the ECG. But we went from 38% to just under 50%. So 12% more echoes and only in that 6%. So overall, we didn't gum up the system by ordering a ton of extra echoes. So we think that these could be deployed without sort of disrupting our usual workflows. If patients were diagnosed with low ejection fraction, the vast majority of them went on some medications, beta blockers, ACE inhibitors, as was directed. So the other disease I'll talk about is hypertrophic cardiomyopathy. This is an expert center in that. But as you know, the ECG is often abnormal, but not always abnormal in people with HCM. About 10% of people will have a normal ECG, even though they have hypertrophic cardiomyopathy. And the ECG can be abnormal in all kinds of different ways. Sometimes it's high voltage. Sometimes it's T-wave inversions. Sometimes it's pseudo-infarct patterns. In a burnt out, it can look very funny. So there is some controversy about whether we should use the ECG to screen for HCM because we end up doing a lot of echoes and there's a lot of uncertainty. We disqualify people who are otherwise healthy from sports. There's a lot of complexities to it. But we do have a very large population of hypertrophic cardiomyopathy patients at Mayo. We have a referral population for genetics and also for a septal myectomy. So we have 3,000 very well phenotyped HCM patients. And we essentially take that population and we break it up into training, validation, and testing populations and do age and sex match controls. And just like we did for low EF, we trained a model, convolutional neural network. This model is also extremely powerful with an AUC of over 0.95. And not only that, but you see, like, this is the model output, it tends to really put its nickel down and say, oh, this is HCM and this is not HCM, which I think is informative to a clinician. And you could draw the line in the sand in terms of sensitivity, specificity, wherever you want along that continuum, and then apply it. Are you screening and you're trying to rule it in, or are you trying to rule it out in another population? You can make it more or less sensitive. After we had identified this, I was rotating on our clinical service, and I was asked to put an ICD in a young woman who was admitted for septal myectomy, and I just wanted to test it. And I looked at her ECG. This ECG was read as normal, I think because they thought that T-wave, that funny V2 was sort of juvenile pattern, but it wasn't picked up as HCM. I don't know if anybody in the room feels strongly that this is a HCM ECG. I don't think so. But the model gave this a 72% likelihood of hypertrophic cardiomyopathy. And it just kind of fun. The next day when I rounded on her after her septal myectomy, her ECG looked maybe a little bit more abnormal. It's sort of fractionated QRS complex, a little bit of ST segment elevation. It looks a little bit more myopathic to me, maybe. But the model then gave it a 2% likelihood of HCM. So something about taking all that abnormal myocardium out of that septum and improving the hemodynamics changed the ECG in a recognizable way to the model, such that it looked less pathognomonic for HCM to our model. So that gave us the idea that maybe these models are useful diagnostically, but maybe they're also could be used somehow to track therapy. Like, is a septal myectomy always going to have this effect? A successful septal myectomy going to look like this? Then we started working with this company, Myocardia, that was recently purchased by BMS. And they had a clinical trial data on patients treated with mavacamten. And most of the patients enrolled in the trial had a positive AI ECG for HCM, but as they were treated over the course of a year with mavacamten, the model output went down. So it gave us the idea that maybe this is sort of like, could be used as a paired diagnostic or a biomarker of drug response. And maybe that would be true for other models as well. So, our AFib risk, does it go down? And if so, does that correlate with a decreased risk of AFib in patients treated with HCM? Or does our low ejection fraction model, if that starts to look positive, are we over-treating these patients with negative inotropic agents? The last example I'll talk about, I could go on all day, but will be atrial fibrillation. But we go through a lot of effort to diagnose AFib in high-risk patients. If you think about people with cryptogenic stroke. We'll put a loop recorder in, costs a few $1,000s. There's monitoring costs on a monthly basis. Often patients complain to us about that. And it's relatively invasive, but we should be able to get some information from the ECG and at least be smart about who we're putting in devices or empirically anticoagulating. So again, you're getting used to looking at these ROC curves, but this model performed well, AUC of about 0.9, but not as good as SEX, not as good as HCM, probably because there are many different roads to atrial fibrillation, and that's a more heterogeneous condition. But still, nonetheless, probably certainly performs better than the clinical risk stratification scores like Charge AF and things like that that we use just looking at clinical variables. After we developed this model, we used a prospectively collected data set at Mayo called the Mayo Clinic Study of Aging. And in these patients, they're very well categorized over years. They get serial Holters and ECGs, such that if they're diagnosed with atrial fibrillation, we know that it's new incident atrial fibrillation. So we could use that data set to say, how well does the AI ECG stratify the population in terms of risk of incident atrial fibrillation? And it does pretty well. Then there are these interesting cases like this where one of my colleagues in neurology came to me after we had developed this model, and he was a co-author on it, to say, could you have helped me with this patient that's been vexing me for years now? He met the patient in 2014 when she presented with what looked like a cardioembolic stroke, but she was a normal sinus rhythm. Tele was just normal sinus rhythm. He did a 24-hour Holter, normal sinus rhythm. So he didn't anticoagulate the patient, and that's what the guidelines would recommend that we do. But you know where this is going. She comes back in 2020 with a devastating stroke in a different vascular distribution, and it looked like it was probably cardioembolic. Still in normal sinus rhythm. She's in the neuro-intensive care unit, and about a week into her hospitalization, she goes into AFib. But probably what was underlying all along was paroxysmal undetected atrial fibrillation. And on the x-axis here is our model output. This is the cut point at which point we would consider the test to be positive. So if you go back 10 years before her first stroke, her ECG was positive. It had crossed that threshold. So you wonder, if we identify patients like this and we monitor them in some way periodically, could we detect patients earlier with atrial fibrillation? Or if you have somebody coming in with what looks like a cryptogenic stroke, but they have a very high AI ECG score for atrial fibrillation, should we just empirically anticoagulate those people? And in that case, maybe prevent sort of a secondary prevention approach. Those are all really important questions and the kinds of things we're interested in asking. So it's sort of surprising to me that guidelines generally don't recommend screening for atrial fibrillation. There's some differences for guidelines around the world, but generally speaking, the guidelines tend to say we don't have enough evidence that screening for AFib and then treating those patients with screen-detected atrial fibrillation actually prevents stroke. So I think of there being like a continuum of knowledge that we have to address to change those guidelines, or at least to demonstrate or answer definitively whether we should be screening for AFib. So I think I've shown you that we can pretty effectively stratify the population for AFib risk. We can use retrospective data sets to do that. But what we don't know is, once we identify patients at risk, how should we monitor them? Is the Apple Watch enough? Do they need a Holter? Do they need 30 days of monitoring? How much do we invest in that? How do we make sure it's cost effective? And the really important question is, once we diagnose atrial fibrillation, is it worthwhile to treat those patients? Because it is possible that screen-detected AFib is actually a low-risk condition. We're seeing that from atrial high rate episodes and things on devices, that there really is a threshold, and symptomatic AFib seems to be a little bit different. So we're now interested in trying to build out this continuum of knowledge. The first trial we did was to answer that first question, which is, how do we best monitor these patients? So we set up a pragmatic clinical trial using our electronic health record and our patient portal. And we just ran the AI on every ECG that had been done at Mayo over the course of 1 year. And we identified low-risk patients and high-risk patients. We cross-referenced that with our clinical data to say, do they have CHA2DS2-VASc risk factors, because we didn't want to detect AFib in people with CHA2DS2-VASc of 0, people that we wouldn't actually anticoagulate. And we also looked to make sure that they didn't have contraindications to anticoagulation. So if somebody had recently been admitted with an intracranial bleed or a bunch of blood transfusions, we didn't want to muddy the waters by having to anticoagulate them. So we found the patients in the sweet spot using electronic means at very low cost. We ran the AI on everybody, and then we just sent these push notifications through our portal. And people would get an alert saying, do you want to be a part of a clinical trial? They could log in, they watched a video for consent, they could consent remotely, and if they consented, we just mailed them a device. One of the first patients that we monitored was a retired Mayo Clinic doctor, and he was living, I think, in Florida or something. And each one of these dots represents an ECG. And he was like in his late 70s. And you could see that he retired sometime around here. But for 15 years or so, his AI was positive for atrial fibrillation, but every one of those ECGs was a normal sinus rhythm. Often some sinus node dysfunction, bradycardia, PACs, but always sinus rhythm. And we mailed him the device, and within about 4 days, he went into AFib. I called him up, and we actually ended up anticoagulating him. But for him, it was kind of cool because he had been contributing data to our retrospective data set just as a Mayo Clinic patient. And it wasn't until we could deploy AI on all that retrospective data to create a new model and then deploy it in a way that actually allowed us to deliver care, even though he was in Boca Raton or something like that, and diagnose AFib and anticoagulate him and hopefully prevent a stroke. It's sort of full circle, data powering clinical insights and changing the way we practice medicine. This guy was a Mayo administrator also in the trial. They must just respond more to our alerts, but he ended up talking to Stat News, which is a medical publication, telling he had basically the same experience as that other doctor. And if you want to read more about this and sort of the pros and cons of this approach, you could pull up this article. But because we took this decentralized, pragmatic approach and we used electronic means, we enrolled patients from 40 states over a very short period of time and at relatively low cost. So all of these patients had been to some Mayo Clinic site at some point and had an ECG. That was the common denominator. So they're a little bit clustered in Florida and Arizona and Minnesota, but they're really all over the place. And I was calling people and telling them, you have AFib, we diagnosed it, in Washington State or Texas or whatever it might have been. So it was a really cool experience to figure out how to deliver care remotely. This is the bottom line. So we monitored people with that device for 4 weeks. And the high-risk patients, those with a high AI ECG score, were 5 times more likely to be diagnosed with atrial fibrillation. And remember, these are uniformly high-risk patients. They have CHA2DS2-VASc scores of around 3.5 or 4. They're mostly in their late 70s. So if we make screening 5 times more efficient, maybe the cost-benefit ratio improves and maybe we can demonstrate that it's worthwhile. So I think what we've done is we knew we could stratify the population. Now we know we can screen them. Next is, should we treat them? And I think that's really the elephant in the room. That's going to take big multi-center trials. Maybe we can collaborate on that in the future if I can ever get a grant for it. I've applied for a lot of grants and haven't gotten one yet for this particular purpose. But I think that's an important question to answer. I'll just show a bunch of other. So long QT syndrome, we have models for that. A cool thing is that even in patients with a normal QT interval, our model will pick up long QT syndrome, which is important. So, sometimes these are the patients that are missed. We can tell the type of long QT syndrome. You probably remember those different delayed repolarization versus prolonged repolarization patterns. But this sort of genotype-phenotype correlations are interesting. Cardiac sarcoidosis is something that when I was a fellow, we were missing all the time. Now we're doing a lot of PET scans and MRIs, and we're picking this up much more. But the ECG is probably going to help us alert for this condition. PVC-mediated cardiomyopathy. I'm an electrophysiologist. I blade a lot of PVCs. Sometimes PVCs are associated with a low EF. Sometimes they're totally incidental. One of our fellows was working on this model, looking at the 12-lead ECG at the time of PVC diagnosis to say, is this somebody who's going to develop low ejection fraction or not? And it's pretty good at that. Arrhythmogenic right ventricular dysplasia. This would be a nice thing for athletes and for athletic screening also works pretty well. So we want to try to get these models into the hands of patients and clinicians around the world. We've kind of democratized it by just putting it into our electronic health record at Mayo, but it's still sort of under a research effort. It's not really clinical. We can't bill for it, obviously. And we want to bring this into the mainstream for clinical care. So you've seen how the dashboard works. This is kind of cool. Does anybody have one of those echo stethoscopes? This is sort of an older version of it, yeah. So the cool idea about echo is that they record a phonocardiogram. So if you're on rounds and you're teaching, you can say, here's a late peaking murmur, here's an opening snap, here's an S3. You can actually be definitive about it. It's not just the most senior person gets to say what they're hearing. And then there are these two metal plates that allow you to inscribe an ECG. And that's important because so you can time the heart sounds to the ECG. That's why they put it there. But they approached us and they said, could we use one of your models on that ECG? And then you take the stethoscope from being just a tool for listening to the heart to actually a way to deploy an AI model on an ECG at the point of care for like very inexpensively. And I'm amazed, but we can actually tune these models to work on this kind of form factor. So even though you put the stethoscope in different positions and the ECGs are going to look quite different, there's enough there that the model actually performs pretty well on the stethoscope. This just came out a couple of weeks ago, but one of my colleagues in Florida, Demi and Desenseu, was interested in screening women for peripartum cardiomyopathy. And in Nigeria, the mortality, peripartum mortality is like about 1% from this condition. So there's a huge unmet need. And so she set up a clinical trial where she did 12 lead ECGs, and we got the stethoscopes from the company, and we used the stethoscope at all these rural health clinics across Nigeria. And it worked really well. Actually, we doubled the pickup rate for cardiomyopathy by using that stethoscope. So a very inexpensive, handheld way to deploy AI at the point of care all around the world. And it actually worked better than the 12 lead ECG, which was surprising to me, but I realized we had taken some old ECG machines from Mayo and shipped them up and shipped them off to these clinics. And there was different sort of noise in the electrical grid and things. So the quality of the ECGs was not exactly the same. So you couldn't just take the model that we had derived and deploy it on the same machine in a different country, because it just didn't work as well. But the stethoscope is not connected to the electrical grid. It's not subject to the same sort of noise and interference. So it actually performed better than a 12 lead ECG, which is great because that's a nice way to deploy it. We're also interested in deploying these models on form factors like the Apple Watch. So using the same sort of approach where we use the portal, we asked people to just transmit through the health kit, the Apple Health Kit, their ECGs to us. We put those into our dashboard. So now we can look at Apple Watch tracings in our dashboard as well. And we got, I can't remember the number, what did it say, 125,000 ECGs. And we had to do a little bit of tuning of our algorithms because the filtering is different on the Apple Watch. We lose some of this sort of high frequency stuff. And this is what the ECG looks like. But the models perform pretty well once we do our tuning with AUCs of 0.86, something in that range. So almost as good, just a little bit of a decrement in quality when we go to a form factor like that. So 2 final slides. We know that we take good care of patients when we take a multidisciplinary approach. None of us is very good in isolation, but when we work with colleagues in imaging, nursing, cardiology, case management, all around the patient, we can deliver high quality care. And I think what we've learned at Mayo is that there are non-traditional members of this care team. And just hiring a bunch of AI engineers into a hospital setting has absolutely allowed us to unlock a tremendous amount of data that was previously just hidden in plain sight. And helped us look at old problems with new eyes and help us move very quickly, iterate quickly. And it's been really a tremendously exciting time. So I think what you can see is that these models do have clinical utility. that they can predict and detect disease, that if we deploy them on stethoscopes and in our electronic health record and on our watches, they're massively scalable, and they're ways to deliver insights at the point of care very inexpensively. And it's a big part of what we're trying to do at Mayo to drive practice innovation. So I would love to take any questions if there are any. Thank you very much.
Thanks for that great talk. So say I'm interested in this entity, it's called microvascular obstruction that occurs after ST elevation myocardial infarction, and it can really only be diagnosed by cardiac MRI, which is expensive. And a lot of times people, we get them out of the hospital so quick and the MRI lab's busy, so they don't get one.
Yeah.
And it has very important prognostic information that if you do have MBO, then your mortality and risk of developing heart failure is very high. And I was wondering, is there a way of looking at just the EKG to determine if or not you have MBO, and how many patients would you need? Say we have all this data paired with EKGs and cardiac MRIs. How many patients would you really need to get, some kind of insight? And then how do you go about doing that? Do you contact your research company? Do they do outside projects, or how would we do something like that?
So the first models, we needed tens of thousands of ECGs because we essentially needed to teach the model how to read an ECG and what to look at. And that the models are built like sort of in layers. So, but now that we've done many of these, we have many of those layers that are very well established, and it's only the final layer that needs to be adjusted. So it knows what are the salient features on the ECG, and it's just a matter of re-weighting those for a condition of interest. So whereas originally we were using millions of ECGs or tens of thousands or hundreds of thousands of ECGs, I showed you our long QT data. It's working pretty well with about 1,000 ECGs. Or ARVC, I think we have less than 500. So as long as we have a data set that's very well adjudicated and you're confident this is that condition versus normal, and you can give us a binary outcome, then we could do it with a few hundred ECGs. Now, if some of them are left bundle and some of them are paced and some of them have CRT and there's a lot of heterogeneity there, then the data set needs to be much larger. So originally what we tried to do is clean the data set so we had kind of uniform inputs. We don't do that anymore because it makes it very hard to deploy the model. So what we like is enough diversity in the ECGs in terms of paced and non-paced, right, left bundle, different rhythms. Then the models are robust to those changes and they can be deployed much more effectively.
What impact do you anticipate this will have on some of those hard to diagnose conditions, such as post-acute COVID syndrome?
Yeah, I think we don't have anything in post-acute COVID, but we did actually develop a model for trying to detect COVID, during the pandemic. Yeah, it works a little bit, but it kind of sort of like wasn't great. It could kind of pick up people who are febrile and tachycardic, and certainly if you're in the ICU, your ECG looks different. So it didn't end up being all that useful. We thought maybe we could screen people getting on airplanes with it, but that was a pipe dream. But so rare conditions. Probably the best example right now is amyloidosis. That's pretty hard to diagnose. Requires expensive tests. But we have a clinical trial like what I've already described for amyloid. And I think we're picking up a lot more amyloidosis because this is deployed at the point of care. The positive predictive value is still relatively low for that condition because it's relatively uncommon. The positive predictive value might be 20% or 15%. But if you go from a sort of exceptionally rare condition to something that's going to be about 10% of them, it's valuable. So, yeah.
So a couple of questions and comments. So, the positive predictive value of any test is going to be dependent on the gold standard, right?
Yeah.
So you're talking about amyloidosis, and sometimes it's an imaging-based diagnosis.
Yeah.
Sometimes you need a tissue diagnosis to do that. When you created your models, how exactly did you assign what the gold standard would be, and are your models continuously updating as you get more data?
Yeah, it's interesting because the definition of a diagnosis can be changed by this, right? Because for HCM patients, these are HCM patients coming through our clinic. Many of them are genotype positive. those that weren't had septal myectomy and tissue diagnoses. So that really was very much a gold standard. But now that we're deploying it, we're picking up a lot more of these cases that the model says is HCM, but they're also hypertensive and they've got a little bit of AS and they're a bit older and there's some asymmetric central hypertrophy and but the genotype negative. They don't have much of a family history and they're 68 years old. So is that clinically significant HCM or not? Is it a mixed picture? So just by making a measurement, you're changing the outcome. So we debate that a little bit because if we continue to refine the model based on a moving target of a diagnosis, then the model performance will shift and there'll be a shift in the nature of patients that we're picking up. It's also technically hard to do that because right now FDA will approve a model and it's a static model. So once you have it, you're kind of stuck with that model. I think that paradigm will probably change because we probably do need to continue to refine these models, and it's foolish to use an old model, but you're raising a lot of interesting questions about sort of that drift and shift in performance and changing of the diagnosis. But generally speaking, when we derive them out of the gate, we're using gold standard diagnoses, tissues, genetics, etc.
Peter, it was just a phenomenal presentation. I mean, clearly, I think you could talk about a lot of diseases and conditions, but to me, what I applaud you and your team and everybody, it's just really fascinating how you guys created this very unique springboard for innovation, and you have groups from different places coming up with ideas and projects. So my question for you is whether you can speak to how was that created? Was that like years of meeting with people to approve this at a regulatory level? It's an investigational approach. As you know, I was at Mayo for several years and remember seeing this AI ECG and you saw it in the network. We got approached by groups that, we want to do this, or now all the companies, as you know, are doing this sort of stuff, but now they're not cleared. How did you guys do this? Because I think irrespective of the disease, just it's the unique setup that you deploy that in that dashboard has allowed just this phenomenal innovation.
I think it's really important that we did that and made it as widely available as possible because there are just tons of people looking at this work and they're testing the models and finding that they work for some applications and not for others. So an example might be postoperative AFib. It's such a common problem. And you think you take our AFib model and you could identify who's going to have postoperative AFib, great, just 2 weeks of amnio, pre-CABG, and get rid of all these long hospitalizations and cardioversions and anticoagulation. Didn't work at all. Didn't work at all. Like the AUC is 0.55 for that. So and if we had sort of guarded the model to ourselves and not just given it to everybody, we wouldn't know that. So you learn where the guardrails are, you learn where it's working, where it's not working, and you just multiply the amount of research and innovation that can happen around that. You also were asking a little bit about sort of where did this start and where is it going? Maybe I'll say a little bit about where it's going. It's no longer even in cardiology only. We just finished a trial using the ECG to screen for cirrhosis. And we have cirrhosis. Cirrhosis is on our dashboard already. But if you're cirrhotic, your QT changes a little bit, your volume status changes, you've got electrolyte abnormalities, and the models can actually pick that up pretty well. And we have a prospective trial that demonstrated that the ECG was actually valuable in screening for non-alcoholic fatty liver disease, as well as other forms of cirrhosis. So even in non-cardiac conditions, the ECG is probably pretty powerful. And then to go back to the beginning of your question, which is kind of like, what's the origin story of this? Paul Friedman, our chair, had this idea that he could create a bloodless laboratory test for potassium because, as we all know, potassium affects the ECG pretty profoundly. So you can hyperkalemia with peak T waves and things. But he thought, couldn't we just use the ECG as a bloodless laboratory test for hyperkalemia, and it could be used while you're titrating heart failure medications, or you're doing diuretics, or you're deciding whether to dialyze somebody. So long before, probably at least 10 or 12 years ago, before we were doing any AI, he was working with other data scientists on like a principal components analysis and feature extraction on the T wave to make these complex models that were sort of pre-machine learning. And it was kind of working pretty well. But then once we hired an AI engineer, and it was right at the time when CNNs and other technologies were coming, it just blew it out of the water in terms of performance. And that was the aha moment that catalyzed all of this work. So sometimes it's just, there might be, you take some technology from some other field and you apply it to your world, and you broaden your scope of collaborators, and that's really when you're throwing gasoline on the fire. And that's also when it's a lot more fun.
Please go ahead.
Yeah.
Sure. Okay. Hey, I'm curious. I'm one of the cardiology fellows, and I do some coding and stuff, and have made apps for medical education and making some now more for patient-focused use. But I'm curious about when you are thinking about getting this into the hands of patients more. Like for you, big picture, what do you envision for that? Do you see it as being through apps and devices and their Apple Watch and stuff like that, or do you see it more as coming, kind of staying more medical and being handed down through their physician or through?
Yeah, I don't exactly know, but to use it for medical purposes, it has to go through FDA, and that's a really expensive process, hiring regulatory consultants and doing retrospective validation and things like that. So we realized that we really couldn't do that. We didn't have any expertise in getting things through FDA. So that's why Mayo Platform was co-founded with a company called Inference, like with an N, Inference. And they saw the value of this, we saw the value of this. So we created a daughter company of Inference and Mayo Clinic called Anumana, which is Sanskrit for inference. And we basically gave all this IP, not gave, but we licensed all this IP into that company. It's the founding IP for that company. And then they could go to capital markets and raise enough money to get these things through FDA. And so they're kind of our go-to-market strategy group. And they're kind of a multi-pronged approach. So they think it might be enterprise software, so it goes into like the ethics of the world and allow health systems to deploy it to all of their doctors and clinicians. But they also realize that there's a lot of ECGs that are just PDFs. So they're also thinking about maybe just take a picture of an ECG and it can kind of analyze it in that way. And then anybody could do it. They're also licensing to things like the Apple Watch or to the ECG, so that it becomes more of a consumer type device. So probably a little bit of everything. I don't know if anybody's exactly figured out how this will be reimbursed, but that's not so important. We just want to try to get it out there.
Peter, we have a number, I know we're almost out of time, but we have a number of online questions. I'm gonna, so Dr. Robert Hauser, one of our colleagues, is asking, is artificial intelligence an important capability for a clinical research organization?
Do you mean, is it important for like a cardiology practice to be able to leverage that?
For a clinical research organization,
clinical research.
Is it something integral that should be
Yeah, I
incorporated?
think so. I think absolutely. And I think for almost any aspect of research these days, whether it's outcomes work, whether it's imaging, whether it's what we're doing here, risk prediction, AI, and even in basic science, you look at the work that AlphaFold is doing and they just got the Nobel Prize for that. Much more nuanced and complex way of looking at genotype-phenotype interactions. It's just going to massively accelerate things.
The other question is from our Chief Medical Officer, Dr. Scott Sharkey. He says, great presentation regarding detection of low EF. Do you have information regarding the incremental value of each of the over the 12 lead EKG?
Incremental value over, well, we try to test that in Eagle. So some of those patients were diagnosed, about 1%, or I can't quite remember exactly, but about 1% were diagnosed with low ejection fraction just by clinical acumen. Echocardiograms have the discretion of the clinicians. But, in the outpatient world, we almost doubled that. So I think the incremental benefit is there.
Dr. Nick Berg, one of the interventional cardiologists, is asking, what about diagnosing coronary disease in patients with?
Yeah, you'd think that would have been our very first priority. And because I'm not an interventionalist, I'm an EP, we have a separate team working on that, which are interventionalists and people in our CAD clinic. And they do have a bunch of models. They're kind of just starting to be published now, but you would think that would have been the first thing we published, and it's going to be 5 years into this. But us and others are doing that as well.
One of our other interventional cardiologists is structural, Dr. Mario Castro, is saying, given all the R&D costs, and efforts, and privatization, what are the expected costs for this AI? Will it replace any current costs or be additive, or will it?
I don't exactly know. I imagine there needs to be some way to recoup the R&D cost. So my guess is that there'll be an enterprise software play, or maybe companies like GE, the Muse software will incorporate this, and there'll be a new negotiated price for standard Muse or the new AI Muse. That dashboard is the way we read ECGs now at Mayo. Nobody goes into document viewer opening up a PDF. So a big part of it is user interface. So we have, I can't remember how many clicks this has gotten, but something like 5,000 unique users at Mayo and over 1 million interactions. So it's the go-to interface for looking at ECGs now. I think a lot of people look at the ECGs that way and they don't even realize they're in the AI dashboard. So there's probably some way to make that software usable and accessible.
You're getting a lot of questions here. I'm going to maybe add one or two more. So Dr. Barkler is saying, you're training all this certain diagnosis, but are you able to learn from the models what they're specifically seeing, or is it a black box?
Yeah. So maybe we'll end on that question because my answer is going to be a little bit long. But that's actually a really important question. So I like this idea of we put all this effort into training the model, and then the model turns around and trains us to see something that we were missing. But in order to do that, you kind of have to peer inside the black box. So Zaki Atia is the lead engineer, the guy who really catalyzed this work. And he just completed his PhD in what's termed explainable AI, so ways to look inside the black box. I'll give you a couple examples of how to do that. One is you could take an ECG and then you can blind the model to some part of the ECG, like go in and remove the P waves or remove the terminal part of the T wave and see when the model stops working. And that's an indirect way to say, oh, the information is actually on the T wave or the P wave or whatever it might be. The other is you can do a heat map or an attentional map, and you can look on an individual ECG and it'll highlight the area of the ECG that's contributing most to model performance. And then you can do like a signal or do like an average median beat and then look over many ECGs and say, oh, it's mostly this or it's mostly that. And I'll just give you an example. For hypertrophic, for AS, when we did that, it was actually the TP segment in the right precordial leads, like a segment you wouldn't normally look at, the segment between the T wave and the P wave. And what we realized is there's actually often right precordial U waves in aortic stenosis. So when you go to clinic, when this is done, if you see an AS patient, look and see if you can see U waves in the right precordium. If you do, the AI has taught you something, because it's amazing how often that has been the case. I've never thought of that before. And the last example is what's called a generative adversarial network, or GAN. And there you actually create, instead of creating the output as a score between 0 and 1, the output is actually, it's a generative AI approach, and you create an ECG. But that ECG is like a caricature or the quintessential ECG for whatever the condition of interest is. When we first started doing that, I was pre-generative AI, so we would get these crazy-looking ECGs. Like, they didn't really look like ECGs, it would be massively exaggerated T waves and things, but it at least told us what features were contributing. I think if we did that now, we could probably get a much nicer-looking ECG. Like, there are examples on the internet of GANs for like a zebra, and what you get is like stripes and a little bit of the signage from the zoo and a bit of the savannah, things that are not really zebra, but they're highly correlated with zebra. So that we kind of had that problem early on, but I think we've moved beyond that in the current landscape. But yes, I think the models can teach us to be better clinicians as well. Otherwise, we're just giving it all over to the machine, which is kind of bleak. But anyway.
Thank you, Peter. This was absolutely